naughty on the back row. So we're going to talk about acetabular fractures, and then it's mostly about very basic stuff. So we're going to talk about diagnosis, management, like emergency management, and then further questions towards the end. Okay, so if people are feeling that there's something burning question, please don't wait till the end. Let's go off and discuss that, because chances are it's relevant to everyone. What's this? Neil, why don't you talk us through this?
So it's APH radiograft of the pelvis center of the left hip.
You have to speak up so everyone can hear you, because there's some naughty people on the back row.
The most obvious abnormality appears to be so it looks like a fracture dislocation of the left femur of the left hip joint,
Yep.
like a lateral mucus crosswise anterior and posterior. So it looks like most likely a posterior wall fracture, but lateral or a GAV.
Okay, so say it's a posterior wall fracture.
Yeah.
Patient's going to be quite a lot of pain.
Yeah.
Yeah. What are your main concerns?
So my main concern is a high energy injury.
Yeah.
So I want to make sure my ATLS is all clear. It's
Beautiful.
isolated.
Beautiful. That's exactly what they want to hear. Okay. Safe. Yeah. What else?
So I then want to know. So I want to know where it's isolated. Yeah, I want to know. So associated injuries, neurovascular status, and general. Yeah. So.
So what's a typical mechanism of injury?
It's normally a dashboard injury.
Yeah.
Basically.
Exactly that. Yeah. And so what are the associated injuries?
So, knee dislocation.
Knee dislocation. Yeah.
Okay.
Calf fraction. It's
Well,
more of a
yeah.
fall for a height.
Yeah.
Can be. Okay, starting that. Okay, so very important you examine the neurovascular status of the limb, exactly as we said. And then what are you going to do?
So after my ATL, it needs emergent reduction. Yeah. So close reduction investigation.
Okay, so say we're here at the Royal London Hospital.
Yeah.
And the patient's in the ED. Yeah. So are we going to do it in the ED? Or
So
take the patient to theatre? What are your thoughts?
So with this, I think it depends on what level of conscious sedation I'm able to get, or what my ED doctor is able to do.
Yeah.
If they're able to give a good conscious sedation, then yes, I'd consider that. Consider it skeletal pin, with the traction pin, perhaps.
Traction pin?
Perhaps, something like this
For-
with close to it. Just for comfort, kind of.
Okay.
And offload the articular surface, I suppose, is the...
Yeah, but you're talking about emergent reduction, so you want to put it back in.
Yeah.
So I think you're right with going down that track and aggressively pursuing that. Okay, traction pin, that's a, if you can't do the treatment you want to do. And there's another reason why you might put a distal femur pin in.
Aid your reduction.
To aid your reduction. So there's a number of things we're going to talk about reduction. And if you have someone who's an amputee, okay, or you're concerned about a knee injury, you don't want to put on the leg. You can't grab the massive thigh. Okay, there's situations where actually putting that pin in can really help you. Yeah. Okay. So. Forget which computer. So. Okay, just describe to me what they're doing. What are they doing?
See, they're doing a close
Sorry. Sorry. I'm going to call you all the wrong name, including the consultants. Don't worry. What are they doing?
So, it's a attempting close reduction of the left hip.
So do you need two people?
No, yes.
You do.
Yeah.
But you can't do this with one person.
Yeah. So the person on the left is stabilizing the pelvis, and
Yeah.
the person on the right is pulling at the hip, applying longitudinal traction.
Yeah. What else is he doing?
He's also rotating the hip with the foot held between his knees.
Yeah. It's
He's
controlling the rotation,
controlling the
isn't
rotation.
it? Yeah. Okay. And it's sort of inline traction. So what situation are you... What's this pre-reduction CT? What's that for? Is that essential? What do you think?
Usually a post-production CT is essential
Yeah. It's really useful, isn't it? Why is it useful?
because if there's a loose fragment, that can be dealt with.
Yeah. Yeah. Okay. Pre-reduction. Why might we do that?
So the femoral neck fracture is non-displaced femoral neck fracture.
Yeah, it's catastrophe, isn't it? So if your X-rays were blurry, or your concerned about method of injury, with any suspicions whatsoever, you're absolutely right. Do that, because otherwise you make a bad situation worse. Yeah? Okay. And you've already told us you're going to examine the neuroplastic status before, because that's really key. Why is that key? Why is that so important? You told us it's important. Why is it so important?
So it's got a high, it could well have an associated vascular, neurologically, you want to know that before you document that before you reduce it.
Because the difference between the injury doing it and you doing it is a lot of money, and has a bearing on what you do next. Okay, so exploration of sciatic nerve isn't necessarily a useful manoeuvre if it was a pre-existing problem and it's got nothing to do with your injury. You expect it to recover. If it doesn't, then surgery's not going to help it. Okay, and we talked about the traction pin being a good thing. If you cannot go to theatre. So why might you go to theatre instead of doing this in the ED? It's about conscious sedation, so you haven't got enough conscious sedation. What's another reason?
Very busy, he's a young guy, I must be struggling, I want to do this.
But you might try.
Yeah.
But you have to be practical, okay? So there are practical reasons why you
Failure
cannot
of
do this.
close reduction, you can't reduce it.
Right, that's a good reason.
So he has other injuries that necessitate immediate latent, for example.
Right, so he's gone for a craniotomy.
Yeah.
Good. Okay, so you're in theatre, you're going to do it in theatre. Yeah. You're not going to say, hang on, let's reduce this hip, let him bleed to death in his brain. Yeah. Good. And failure of close reduction in theatre, you've written pelvic surgeon there. So why a pelvic surgeon?
Because then you need to
Okay.
fix, for example, in this, if it's a fracture dislocation.
So you're at the Homerton, you've got somehow this patient has been brought to you. You take somehow you've not managed to do a close reduction, but you want to take the patient to theatre, and you refer to us, and we say we've got no beds. So what happens next?
Even we've been unable to close reduce it under anesthesia.
Any offers? Refer it elsewhere? Who's going to take it? Royal London got no beds, King's is going to take it. Hassan is looking wise though. No?
CT is there.
CT is, yeah, CT is done. CT shows posterior wall fracture, dislocated hip. So the patient is going to come to harm left like that, right? So no beds, we need to transfer the patient to the ED. Yeah, take them to theatre and then put them in recovery, or the usual things we do to ensure the patient is safe. Okay, so these are various descriptions of manoeuvres for a posterior dislocation. And you see there's basically increasing numbers of personnel, increasing levels of desperation, and don't do this. Okay, you have one attempt at close reduction, and then you go to theatre and do the reduction in theatre, because you're just wasting time and resources otherwise. Okay, so who's seen an anterior dislocation? Yeah. Okay, everyone's coming out. And how do you reduce it? What's different about the reduction manoeuvre?
First of all, the
Pull it straight. Yeah.
underlocation is different.
It's an abduction, the hip is abducted usually.
Can be. So what's the position of the leg when you're posterior dislocation is what rotation?
Internal rotation. This is external rotation.
Okay. Yeah. So, and maybe you only have one X-ray, right? Maybe you're quite confident there's no femoral neck fracture. Doesn't look like femoral neck fracture there. So, if you do the posterior reduction manoeuvre on this, it won't go back in. So this looks like they've sort of flexed it up, but I think the key point is to inline traction, and it's usually an extension because it's just the head of the femur just resting in the soft tissue. So the take-home message here is any dislocated hip is an emergency. Native hip dislocation is an emergency. It should go back in immediately, and if there's some other life-threatening situation that precludes it, then you put a traction pin in. We put a traction pin in to aid your reduction. Good. You've got these points. Okay. So who's got the plastic pelvis? Yeah, you're in the hot seat. So, anterior column is quite a big structure. Anterior column comes from the symphysis, all the way up here, up the superior ramus, the front of the acetabulum, and up all the way up the ilium. You can see it's much bigger. Posterior column in blue is here, ischium, posterior half of the acetabulum, and it ends just at the top of the greater sciatic notch. So it's a much smaller structure. And the weight is transmitted, the weight of the body is transmitted through the anterior and posterior columns. And we use this understanding to classify fractures and also to guide our treatment. This three-dimensional structure is quite complicated. And when we look at a plain X-ray, we did we make this diagram? I think this is your diagram here. Quite possibly. Oh dear. Never mind. We're here to learn the name of the lines, right?
Leading and outline.
That'll come, but the important thing is doing the work, right? So when we look at the X-ray gives us a two-dimensional picture, and the lines represent the condensation of the cortices and the overall shape of that. So, so these are the lines, 1, 2, 3, 4, 5, 6 lines. We're going to go through each one. You're going to tell me what they are. Well, I think that's the presentation tells me what it is. Iliopectoral line. I think we need people to come up and mark on this one. You're off. You're the first candidate. I want you to stand to the side and just mark with your finger where you think that line is. And then the answer will flash up. Then come to the other side. Stand around the flip chart. Iliopectoral line. So this is representing which column?
Anterior.
Anterior column. So just think, where is the... So show me the most medial part of that line. Most medial part is closest to the midline. Excellent, yeah. Yes, remember your symphysis, feel it on yourself, right at the front of the pelvis. Your ischium, this is the ischium here, the seat bones, that's what you sit on. That's the back of the pelvis. Yeah? Well, I think you're spot on. All right, next candidate. See, this is why you have to sit at the front. Okay, so no, go and stand up. All right, so that is the anterior column. All right. So what column is this?
Posterior.
Posterior column. So where's that line? Ilioischial. Yes.
Yeah.
Yes. Okay. Should we see? Is he right? Awesome. You nailed it. Okay. So posterior column. Okay. The teardrop. So what does the teardrop represent, guys?
Most medial part of the...
It's the medial wall of the
Medial
acetabular.
wall.
Yeah. Okay. Is he right?
Yeah.
Yeah. Everyone's wondering, is she going to go left, right, back, front? Radiographic roof. This is an easy one, I think. Who's going to come and do this? Christoph. You know this? No? Not feeling like getting up?
Is the apple...
Come and show us. You know, if we had a laser pointer and you had it right at the back, that would be even more awkward.
I think
It's getting some design.
Okay, well, let's see. Yeah. Okay, what's left? What's left, guys?
Anterior wall and
Posterior wall.
Okay, now remember, the wall is this flat piece of bone here. Okay? Now you don't see the flat piece of bone on the X-ray, you see the margin of it. So in the original description of the classification, apparently, it's described as the lip or rim. Rim, anterior rim. So this is more tricky. So these two are, I think, the most difficult lines. And does anyone know? Does anyone have a technique for finding it?
Because the acetabulum is antiverted.
Yes.
So
yes.
the more medial line is the anterior and the more lateral on the AP radiograph would be the posterior.
So what about people with acetabular retroversion?
If it is not displastic.
If it's not dysplastic, how do you know if it's dysplastic? are looking at the x-rays. It becomes like a circular thing. But what else can you use to reference?
We use the teardrop.
You can use the teardrop most medial part. Yeah, I mean the teardrop's a separate part of the acetabulum.
So
For the version.
the margin merging
Merging.
with the ischium
Yes.
lower down is
Yes.
the posterior
Yes.
wall margin.
Yes.
Yeah.
Yes.
Crossing
So,
sign.
I'm going to show you. Crossing signs to do with retroversion. Okay, so you've got the key, which is to find the anterior rim, which represents the border of the anterior wall. You start at the lower border of the superior ramus. So remember, superior ramus is part of the anterior column. Yeah, and you come into a line that's crossing the acetabulum. Okay, and remember, in the majority of cases, the posterior wall is a much bigger structure. So the anterior wall will be less of an overlap with the femoral head. And as I said, the ischium, if you follow the ischium up, you come into the other line, which represents the posterior rim. But these are quite difficult lines to see. So know the theory and know how to look for them. And then in the exam, you can say, well, I would take a line following up the outside of the ischium here, and that should run into the posterior rim, and here it's this line underneath. Okay. What's this? Hassan's being very quiet. It's his turn now.
And that's associated both column injury because both the iliopectineal and the ilioischial lines are displaced.
Okay. Is there any other fracture type where both lines are displaced?
Transverse.
Transverse.
T.
T-shape.
T-type fracture.
Yeah. And one more.
Anterior column, posterior column.
Yes.
Yeah. So why are you running straight into associated both column? I'm not saying you're wrong.
May I say something? I
Yes.
think this is an associated pelvic and acetabular injury
Okay.
because I think it is an APC2 on the right side, and I think it also has central dislocation.
Okay. So why are you calling it APC2? Because
I think it is a bit widened. The symphysis is a bit
symphysis is
widened.
widened. Yeah.
Yes, and also the right sacroiliac
Yeah.
seems disturbed.
Yeah.
So if it is not APC2, then probably it is combined mechanism.
So about 10 to 15% of acetabular fractures have an associated pelvic ring injury as well. So yeah.
I think it's T-type fracture.
You think it's a T-type fracture? Yeah. Why are you saying that?
It is clearly disrupt, iliopectineal disrupt, and the obturator, and the fracture extended the obturator foramen,
Yeah.
and they're associated with the pelvic injury as well.
So there's a particular thing on here which is characteristic of the way T-type fractures behave. Does everyone know what we're talking about with T-type? Does anyone not know what we're talking about? Can I ask anyone any question about T-type fracture? So we'll talk more about the classification. I think it will become more clear. But yes, basically, iliopectineal line is disrupted, ilioischial line is disrupted, your teardrop is in half, and your roof is in pieces. That's also gone? Oh dear. Okay. So here we use the Maternal Classification, and in the UK generally it's pretty unusual that people use the AO classification or any other classification. This is probably the one which is in commonest use. I think it's the easiest one to understand. So that's why we use it, and that's why we talk about it. And it might seem that there's 10 different fracture types, but 5 elementary with 1 fracture line, 5 associated with more than 1 fracture line. So this is a suggestion, okay? You can just say these are the 5 elementary and these are the 5 associated, but it's very boring, it's difficult to remember, and it doesn't necessarily make that much sense. So this is a different approach because this is something I wrote with another surgeon who's not in this unit, and our thinking, if you think like a surgeon, and especially if you come out with this in the exam, then it shows you're thinking like a surgeon, which is, I think, quite impressive, because the exam is to be a surgeon. So, posterior fracture dislocations are treated with what approach? If you're going to operate on them, you're going to use a posterior approach. Right, posterior approach. So if we look at those first, that takes one big category out. What's that?
Posterior wall and posterior column.
Okay. What's that?
Transverse posterior wall and
So somebody said hemi, and this is not your fault at all. It's just to do with the terminology. Hemi is the anterior column posterior hemi transverse, yeah, which is basically a both column fracture, just the location of the fracture line. We'll talk about where it is, but it's different. So this is a transverse posterior wall
posterior column.
and a posterior column posterior. So the terminology, just remember that hemi, if hemi is in there, is to do with both column fracture. So anterior injuries we're going to treat with what? Anterior approach. Okay. Maybe. If we're going to operate on them, we're going to treat them with an anterior approach. So anterior wall. So sometimes we see on the CT scan, and there's a report, anterior wall fracture. What do they mean? Is it common? No. What do they usually mean? What do we find when we talk about it in the meeting when they say there's an anterior wall fracture? They're usually talking about, so this anterior wall, right, fracture through here there's another name for it, root of ramus. Okay, so that's the commonest thing we see. It might technically involve the anterior wall, but actually it's a pelvic ring fracture, root of ramus. Yeah, and you know that because if you look through the other cuts, the rest of the acetabulum looks absolutely fine. There's no fracture line except right at the root of ramus. And then you look carefully at the sacrum at the back, there's usually some injury. Okay, and there's another situation where we see isolated anterior wall fractures, which you've already talked about.
Dislocations.
Right, so I've operated once on an anterior wall fracture associated with dislocation. It was the first time I'd seen it as a consultant. Needs an operation, so we did an anterior approach to it because it was unstable. But it's rare to find in isolation. It's even rarer that it needs surgery. And anterior column fractures, we do see them, but usually there's an undisplaced fracture going through the posterior column somewhere. What's this?
Anterior column posterior transverse.
So that's the hemi, yeah? And that's an associated injury, which is a both column fracture, but is classified with the anterior types. And how do we treat this anterior column posterior hemi transverse? How do we treat it in this unit?
Percutaneous column screws.
I think all the pelvic team are operating, aren't they? Oh, apart from you, you're sort of honouring pelvic.
They don't need to learn. They're in a pelvic team, isn't it?
They know it already.
It's a rest.
So what are you saying? Screws? So most of them are displaced. So what are the characteristics of anterior column posterior hemi transverse? The fracture line crosses anterior and posterior column. Yeah. Do you know what I mean by constant fragment? Yeah. I can't ask the consultants.
Constant fragment at calcaneus fractures.
Calcaneus fractures. Yeah. So a lot of so acetabulum is a periarticular fracture, right? And in describing periarticular fractures, we talk there's a constant, which is still attached to it's your constant reference, still attached to the rest of the body. So in the acetabulum, your constant fragment is next to the sacroiliac joint, yeah. And in the ACPH, if you notice your constant fragment still forms part of the acetabulum. You've got some dome attached to that. Yeah, that's what makes it different.
From the column.
Say again?
From the both column variation.
It's different from the both column. So when you have a both column fracture, no part of the acetabulum is attached to the constant. And you'll see it as you look down the CT scan. Other characteristics of this that differentiate from both columns. So
Spur sign.
spur sign, yeah, we'll talk about that later. What else? Which age group do they occur in this, typically?
It's the old age. Usually, anterior posterior is for the old age.
Old age, yeah, characteristic old age. And prognosis, good, bad? Easy to treat? Difficult? Anatomical reduction?
Difficult because when you reduct one side, you cannot reduce other side. Usually you need that one stage operation.
So with an associated both column fracture, which is not this, the acetabulum is detached from everything else, and frequently it goes and settles in a medialized position, and it looks like an acetabulum. So you can, in some situations, maybe not so much our unit, but elsewhere, they'll treat them conservatively, thinking, okay, when everything heals, everything will be a bit strange, but there'll still be a socket of sorts. Whereas at this, you get incongruence, because part of it is still attached, the rest of it breaks off and goes elsewhere. Yeah. Okay. So our approach to this, in this unit, is generally what? Do we tend to operate or not? Nearly always, yeah. Nearly always they're old people, they're a periarticular fracture in an old person that's displaced in a large central joint will generally not do well without operation. Yeah. And we tend to start with anterior approach if we're doing fixation only. Do young people get these fractures? They do, yeah, they do. They do, we do see them. Okay. How many fracture lines? One. So the transverse fracture is a single fracture line, that makes it elementary, that crosses anterior and posterior column. So that is a special thing about the transverse fracture. There's an FRCS MCQ that says, what is the best prognosis fracture to have? And the answer is this. But actually, it's very difficult to treat. Why is it difficult to treat? Why is reducing a two-part fracture so hard?
Because there might be in one view is reduced and otherwise it's open.
Because you say again?
You cannot exposure to the other side. When
Exposure
you
to the
reduce
side,
from
yeah.
anterior might be posterior is open.
Yeah, so you see one small part of it, whatever approach you do, you see at best two surfaces of it. Yeah. And so getting a perfect reduction, it can look, the surface you're looking at can look great. The x-rays can look great. And then you do a CT scan or you look in the back or the other side, and it's not reduced. Okay, because actually two-dimensional imaging doesn't tell you everything, which is what we tend to use in theatre. And what you visualize gives you only part of the 360. So they are difficult. And approach, anterior, posterior.
Usually posterior.
Why? Because people like it.
Right, yeah, it's because it's more common approach. More
Okay,
have
people
to-
more confident with it, more people can do it.
Yeah.
Yeah.
And
It's a wide surface area for placing your hardware, one plate or two plates. And then
Okay.
you can,
So your surface area posteriorly is this. This is the posterior column. We can expose all of it with a posterior approach. Yeah, all the way up here. With an anterior approach, we can expose all of this and medially all of this, all the way back to the sacroiliac joint. I think in terms of surface area, you have a better surface to lay plates on if you do anterior approach. But you're right, posterior approach is more common for transverse fractures because of the reduction technique. Because actually you can get hold of the ischium much better than you get hold of this bone is not strong or good. Whereas this is like a monster rock. Okay, so you can put Shanspin, you can put a Youngblood, you can put reduction clamps, you can do more powerful reduction maneuvers with posterior approach. But sometimes you find that the way the fracture is rotated, the posterior column is quite nicely lined up, and actually the major displacement is anterior. And that's a good reason to go in anterior and use maybe different reduction techniques. Associated T-type, so the imaging we were looking at before, that was a T-type fracture basically, for the reasons. So this behaves differently from that in that you're trying to restore the shape of the acetabulum, but what's happening in the anterior column, posterior column, is happening independently. So as hard as it is to move half of probably a quarter of the pelvis to line it up with the bit that's constant, this is even harder because you have less of a large piece, but you've got to get each side right and each side properly referenced with the other. Probably more of a challenge. Okay, so we've talked about this. We talked about anterior column, posterior, hemi-transverse. So the different features associated with both column more often in young people, but does happen in old people too. And as you run through the CT scan and follow the constant down, you can see that there's no dome. Yeah? You won't come into any dome that's attached, there'll be a fracture line crossing. But for that reason, some people treat them a lot. So that's your constant, number 1. That's fragment number 2, anterior column. And fragment number 3, we're attached to the issue. Christoph was telling us about the spur sign. Yes. Tell us about the spur sign.
Shall I show it?
Yeah. Okay. What is it? Do you know what it is?
The part of the acetabular that
Still attached to the axial skeleton.
well, actually, except that there is no part of the acetabular attached to the axial skeleton.
So you're both right. It's not part of the acetabular. Yeah, it's part of the ilium. Yeah, because there's no part of the acetabular still attached to the axial skeleton, and so you've got a spike of bone left behind that you see. And for maximum gold star brownie points, what's strange about this spur sign? There's something strange about this spur sign and this X-ray with this spur sign.
The SI joint is disrupted as well. It's like the,
Okay, never mind, then it's not that. So spur sign is a sign of what kind of fracture? Associated with the column, yeah. And you see it most clearly on which view? Obturator oblique. Okay, and this is? AP pelvis. So usually on the AP pelvis you don't see it. Okay, this is like a really terrible example because it's very dramatic, but often you don't see it on the AP pelvis, you see it on the obturator oblique. Okay, so this should work now. As you follow the axial CT scan down, here's constant. Yeah, we're following it down, following it down. Is it attached to the acetabulum? Is there any dome connected to that piece as you go down, or not? No. Okay, here's the dome, right? So you see various pieces of dome around the place, but it doesn't look like one is attached to the constant as you follow it down. But remember, the orientation of the fracture line is in the axial plane, so you might miss it, okay? If you see dome attached to the constant, then you know that it's not ABC. But if you don't, you have to just check, look at the other view, look at maybe a corona to confirm. So it's the same patient. And as we follow the constant down, so in fact you're looking at dome now running back into constant because the constant's further back. So there's the constant at the back. So was there any dome on it? Again, look for the pieces of dome. There's dome, there's dome. Smashed up dome, more dome. What do you think? Attached or not attached? Not attached. So this is a both columns. So try not to say both column. Remember, we've how many types of both column? Associated both column is a specific entity. Yeah. And are we right? The same fracture. So you see, looking sort of posteromedially, you look into the joint there, and the dome is completely separated from the constant fragment. Quite a big piece of constant. Okay. Any questions about looking at the CT? I think you all know what to do. It's pretty straightforward. That's just to differentiate associated both column and anterior column, posterior transverse. So this is just to demonstrate CT shows you things that you won't see on plain X-rays. And we don't, it's not our practice, is it, to get judo views? And when do we get judo views? Intraoperatively, yeah, Post-operatively, yeah. So the intraoperative images, we're actually moving the image intensifier rather than the patient. So they're not strictly speaking judo views, but they show us the same information. And post-op, in the clinic, we get judo views to look at acetabular fractures. But the CT shows us other things, not just the columns. It shows us, we talked about CT for after reduction of a dislocated hip. Yeah, you said that there can be fragments in the joint. Yeah. So what about, what's this? Can anyone make out what's going on? You can see on the image on the left, there's good congruence of the acetabulum. What's happened on the right? Posterior wall is fractured, yeah. And what about the shape of the
Marginal impingement.
marginal impingement? Yeah, we call it something else.
Impaction.
Impaction. Impaction. Yeah, where it's crushed in. Yeah. Okay, and there it is. Yeah, you see the floor of the acetabulum, a little blood, and you can see the edge of the joint. So there, right? That's the edge of where the acetabulum should be, and there's a bit of joint surface that's been pushed all the way down. What things affect prognosis? So we talked about fracture pattern and the type of fracture that affects your prognosis. What else? Who have you seen doing badly? So me operating on a patient, that probably affects the prognosis. What else? Associated injuries? Not so much. So this is really very heavily investigated and well described. Associated injuries doesn't come up there. But yeah, you know, if you're decapitated, that's bad news.
Patient factors.
What?
Patient factors.
Patient factors, yeah. What patient factors?
It's their old osteoporotic bone.
Why, so I love this, why osteoporotic bone? How does it behave differently?
It's harder to fix. It's harder to manipulate.
And what about the fracture pattern? So apart from the classification, we're not talking about classification now, there's something else about how osteoporotic bone breaks. How does it break?
More comminution?
Yes, it's smashed. Yeah, totally smashed. And we see fragility fractures where the acetabulum smashed. Yeah, and bringing all of those pieces together. So we know the principles of articular fracture are absolute stability, anatomical reduction, absolute stability. Can't do that with these fractures. Yeah? How do you fix 100 pieces or even 10 pieces? It's really difficult. Impossible, some might say. So yeah, age of patient. And so the age of patient does have a bearing on prognosis, and a lot of the prognosis papers have been written looking at traditional techniques. Okay, if we fix that, we have a fracture, we have to fix it. We put a plate and screws in. Oh, now it isn't good. But we've got other techniques, haven't we? Yeah. So for marginal impaction, we can use a technique where we fill it with a bone, we elevate the fragment, fill it with a bone filler, and then fix the fracture. Or we have replace. Yeah. So yeah, patient factors. Age is a big one. Age and osteoporosis. What's the connection between age and osteoporosis? Does everyone old have osteoporosis? Or is it a disease that affects a few people? What's the connection? What's the correlation?
There's a strong correlation for increasing osteoporosis with age.
Everyone gets it.
Yeah.
Everyone gets it, right? In our
Everyone's scared.
mid-70s, we'll all have osteoporosis, apart from the maybe top 10%. And with increasing age, it's inevitable. Yeah. Okay. What else?
Dislocation.
Dislocation's bad. Why is that bad?
AVN, chances of AVN increase.
Yeah. Yeah, AVN is bad. What's the treatment for AVN?
Replace.
Hip replacement. Yeah, nothing else necessarily works that well. Okay, so this paper is from the famous Matter from 2012, but very good paper, looking at large number, 816 hips, and they followed up 79% of them for 20 years. So very long-term follow-up of acetabular fractures treated operatively. So this is a great study looking at prognostic factors, and very long follow-up, and many of them have no hip replacement, 20 years afterwards. Okay? So, and we see this all over the body, so plateau fractures that extend into the joint, very few of them having knee replacement. Acetabular fractures in young people, reduced and fixed anatomically, very few of them are having hip replacement. But people in that category, it's not true. So you can see the biggest factor here is age. Yeah. So and they're talking about traditional techniques. Yeah. So for age, it's a very strong predictor of the need for hip arthroplasty. And then other things as you would expect: damage to the femoral head, marginal impaction because it's more difficult to treat, incongruency, non-anatomical reduction. Somebody asked about approaches. Has anyone seen an extended iliofemoral approach? Wow, Miss Angus seen it.
Assisted.
Yeah, tell us about it.
I can't remember. I know it's horrible.
Horrible.
Yeah.
Okay, so that's the word most commonly used
I'm not going to
in a
do it.
survey of UK pelvic and acetabular surgeons.
I made up my mind not doing it ever.
So basically, you flay open the patient. You go across the crest.
Yeah.
You come down the
Strip
thigh,
it down.
and you flay open the anterior and posterior aspects of the acetabular. So great for transverse fractures because you can see front and back at the same time.
It's like the butcher shop.
Almost 100% infection rate. Okay, and we were surveyed. A group of 20 of us from around the country were surveyed. How many of these approaches do you do? And one of the older surgeons in another unit wanted to know how we're going to best support young surgeons in doing this approach. And the answer is nobody wants to do it. It's not necessary anymore. We have other techniques that replace the need for it. But in those days, it was an indicator for a relatively poor prognosis, although not as bad as the UK experience. Okay, so to summarise, and then maybe we'll talk about your questions. Emergency treatment for the native hip dislocation. You're experts at the lines of the acetabulum to interpret plain X-rays, and we still occasionally send plain X-rays, but CT scan, for all the reasons we've talked about, is the contemporary way of investigating patients. Julia views a post-op, and there are predictors that we know will give us a poor outcome. Okay, can I switch now, Hassan, to my PowerPoint, which has recorded the... So what do I do? I just unplug it?
Just unplug it. Just change the...
Because we had some questions about what you wanted to know about particularly. So one thing was approaches. So extended iliofemoral, no, it's horrible, as Miss Anne says, and let's go to the end. Look away, everyone. A bit seasick otherwise. Oh, I missed it. Ilioinguinal, what is, so this is another question that people asked at the beginning. What is the place of the ilioinguinal in modern pelvic and acetabular surgery? And good question. It gives you different visualizations. The ilioinguinal, the skin incision is anterior. The stopper approach is a transverse incision here. And with the mobile window, you can access any part of the anterior column, any part of the medial aspect of this hemipelvis. The ilioinguinal is a curved incision that gives you access to this part of the anterior column and this part of the anterior column. And in this unit, we have used it recently, to get to exactly this part of the anterior column right above the hip. Because actually, if you're coming in from here and you want to get a buttress down there, the angle of attack isn't ideal. So it's a very limited indication, really. There are surgeons who are trained in the ilioinguinal who use it for all anterior column fractures, anything where they want to do an anterior approach. And I worked with one of them who demonstrated to me, look, you can get to the sacroiliac joint through your lateral window here by putting some sort of instrument in here, but most surgeons who do that approach tend not to expose the sacroiliac joint in the same way. And they could do, but they tend not to. They tend to focus on what they can see most easily. And can you get to the quadrilateral plate here? Yes, you can place an instrument on it through this approach, but you can't put a medial buttress plate with an ilioinguinal approach, which is something we find really useful, especially for patients, especially for the osteoporotic patients, so you want to lateralize them. Yeah. but in many cases. In many periarticular fractures, there's a concept of applying a buttress somewhere to give you a stable surface to push against to do the rest of your reduction. So we tend to find medial is when we have a fracture that crosses both columns, which is behaving as both columns are independent. We find a medial buttress plate is often a good way to start. So can you fix an acetabular fracture through an ideal approach? You can, but I think it's less versatile. But the stop approach, the modified stop approach that we do has limitations, and so there's a place for using at least part of it, part of the ideal. Yeah. Other approaches. What other approaches can we do? Posterior approach. Cocker-Langenbeck. Yeah. You might have seen a different posterior approach here. No? None of the pelvic team. Gibson. Heard of that? Gibson approach? No? So very similar. So it's posterior approach, but just using an interval which is further forwards. So Cocker-Langenbeck gives you all of the posterior column really well, but with Gibson you come more up here, which is where our anatomic plates, are fixed here into this part. So it's less. You have less of a struggle with the muscle. Other approaches.
Trochanteric flip osteotomy. Trochanteric flip osteotomy.
Trochanteric flip osteotomy. Yeah. What do we use that for?
Femoral head fractures.
Say again?
Femoral head fractures.
Femoral head fractures, yeah. So femoral head fractures you can treat from an anterior approach or posterior approach. So if they're in association with a posterior acetabular injury, then you want to do a posterior approach. When you do a posterior approach, you tend not to see the fracture. The fracture tends to be quite an anterior fracture, anterior or superior. And so the trochanteric flip, you take a part of the greater trochanter off, take it up like a sleeve with medius and vastus still attached to it, and then the capsule is usually, you can do a Z capsulotomy, but the capsule is usually ripped from the injury, and then you get great visualization of the femoral head. Although it's a bit awkward, you have to put the leg in quite an extreme position to get to the front of the femoral head. Yeah. Yeah. Yeah, okay. I mean, those are the approaches we use. So there are other approaches, but I don't think you should talk about them, describe them. You just start digging a hole and talking about something that is historical. I guess if you're asked in the exam, you'd be very unlucky to be asked about the triradiate approach. So the classic indication for an extended iliofemoral is an ABC, associated both column fracture, with a separate sciatic notch fragment. So this is separate, like a segment, out of the posterior column, and that's really difficult to treat because you've got to reference that back to the right place while still making sure that the reduction here is great. But we have another way of doing that. That's a separate presentation. So approaches: anterior approach, posterior approach, ilioinguinal, modified stopper, Cocker-Langenbeck, Gibson. Not the extended iliofemoral, it's horrible. Who to fix? Are we fix happy? So I think there's 60 pelvic acetabular surgeons in the UK, and 40 of us are on the same WhatsApp group, and you get very diverse opinions about what to do with something. But there's a huge amount of tolerance. People tend not to get upset. There's like this recognition that some people are just very conservative, and that's what they do, and actually the patients don't have another option because there is one or two surgeons in their unit, that's it. And so we are not in an extreme position with the patients we fix. Definitely not. But yes, there are some people treating the same patients we fix with conservative measures. But we do more surgery because we believe the outcome is better.